Good afternoon, everyone. This is Dr. Faisal Khan. I'm the CEO of the Houston Medical Clubship. Today we have Dr. Daniel Neri from UNAM Mexico City Medical School, and he will be presenting axonal myeloneuropathy. Dr. Neri is aspiring to become a future neurologist. Welcome aboard.
Thank you, Doctor, for the presentation. Thank you, everyone, to having me here. I will present axonal myeloneuropathy. It's a disorder that affects the myelin, the spinal cord, and the peripheral nerves. First, I will talk about the definition, some classification, some etiology, and then the diagnosis and the treatment for this pathology. Myeloneuropathy is a disorder which affects both the spinal cord and peripheral nerves, and for this reason you will have a wide diverse symptoms, and these symptoms may overlap between each other. So this is the reason why the diagnosis is very challenging. The classification according to different etiology are six main types: metabolic, infectious, hereditary disorders, drugs, paraneoplastic, and inflammatory. The most common cause of metabolic myeloneuropathy are due to vitamin deficiency, like vitamin B12 deficiency, folic acid deficiency, vitamin E deficiency, and also copper deficiency. HIV and HTLV are the most common causes of infections myeloneuropathy, and some hereditary disorders you should suspect in a patient with a past medical history of myeloneuropathy. One of the main disorder is adrenal myeloneuropathy. And some drugs like nitrous oxide and thioquinol, they may cause myeloneuropathy in some patients. The most common cancer that is related with myeloneuropathy is breast cancer, but also there are some lymphomas that can cause myeloneuropathy. There are many inflammatory diseases, but the most important: Sjogren myeloneuropathy and sarcoidosis myeloneuropathy. The most important when you have a suspect case of myeloneuropathy is first the clinical suspicion or the clinical recognition. Then if you have this myeloneuropathy suspected, you need to perform this blood workup in the patient, including levels of vitamin B12, folic acid levels, or vitamin B9, and other vitamins levels like vitamin D, E, but also other metabolites like iron and calcium. Okay. It is also important to perform MRI of the brain and spinal cord with contrast to rule out any compressive lesion in the central nervous system, and it's important to perform EMG and NCS to detect the polyneuropathy in the patient. Once you have all these tests, you will be able to perform a diagnosis and treat the specific cause. It's important to treat to obtain a better prognosis for your patient. There are many wide symptoms across these patients. If the spinal cord is involved in this pathology, you will have a patient with Lermite signs. You can also have pyramidal signs like hyperreflexia and spastic paresis. Also, if the dorsal column of the spinal cord is affected, the patient can have sensory ataxia, and loss of vibration and proprioception, and some patients present with autonomic dysfunction. In peripheral nerves involvement, present with distal or acral paresthesia, neuropathic pain, hypoesthesia, and muscle atrophy. There are some specific signs and symptoms according to the different etiology. One of the main etiology of myeloneuropathy is subacute combined degeneration that can be caused by many different vitamins, including vitamin B12, folic acid deficiency, vitamin E deficiency, now NO intoxication, and copper deficiency. Subacute combined degeneration is when is asymmetric demyelination of the spinal cord tracts due to insufficient or inadequate production or maintenance of the myelin. So the parts of the spinal cord that will affect mostly is the dorsal columns and the lateral columns. Dorsal column affection could give you some symptoms like loss of vibration, perception, two-point discrimination, losing tactile sensation, and sensory ataxia with Romberg sign positive. When the lateral columns is affected, you have these upper motor neuron signs like pyramidal signs with increasing the deep tendon reflexes, also with extensor plantar response, so Babinski sign positive, and some paresis. This kind of paresis is spastic paresis. Also, you can have spinocerebellar tract lesion or demyelination, and can contribute to the spinal ataxia. You can have autonomic dysfunction with erectile dysfunction, incontinence, and orthostatic hypertension. In a long-term subacute combined degeneration, the patient could present with depression, dementia, and paranoia. The most common or the most important etiology for a subacute combined degeneration is vitamin B12 deficiency. There are three main causes of vitamin B12 deficiency. One is decreasing intake, the second decreasing absorption, and the third one is increasing requirements, such as pregnant woman. Decreasing absorption can be caused by this autoimmune disease called pernicious anemia, which is with the body produce antibodies to the intrinsic factor protein, and then the intrinsic factor protein cannot bind to vitamin B12, and the vitamin B12 couldn't be absorbed as normal. The symptoms present with this subacute combined degeneration of the spinal cord with this posterolateral syndrome, but can also present with peripheral neuropathy. The earliest sign of vitamin B12 deficiency is the acral paresthesia. Can also present with pain, hypoesthesia, and muscle atrophy. Vitamin B12 deficiency cause megaloblastic anemia or macrocytic anemia. For this reason, the patient could present with glossitis, pallor, and sclera icterus due to the anemia, but also because the hemolysis of the red blood cells. It's important to measure the vitamin B12 levels and also perform MRI and EMG, like I told you. Here is an image of an MRI of a patient with vitamin B12 deficiency. When you can see the lesion in the back side of the spinal cord on the posterior columns. This is a long tract lesion. You can also see the axonal peripheral neuropathy on the EMG test. The treatment is with vitamin B12 or cobalamin intramuscular injections daily for 5 days and then monthly. 1,000 micrograms per day. And the neurology recovery may be incomplete, but some improvement after 6 or 12 months with the therapy. It's important to differentiate the vitamin B12 deficiency versus folic acid deficiency. The folic acid deficiency is less common than vitamin B12 deficiency. You can have a patient increase, well, there are some factors that increase the risk of folic acid deficiency, such as chronic alcohol use, also with some medications like proton pump inhibitors and phenytoin and metformin. The difference between how you differentiate between vitamin B12 deficiency and folic acid deficiency using this or measuring this metabolite called methylmalonic acid. A patient with vitamin B12 deficiency will have elevated methylmalonic acid levels because it accumulates due to the vitamin B12 deficiency. The treatment for the both disorder is to give the vitamin in the patient. Why you have this demyelination process in your body with a vitamin B12 deficiency or folic acid deficiency is because you affect the pathways that you affect the pathways relate to fatty acid metabolism. With this deficiency, vitamin B12, you cannot have enough metabolites that can to produce fatty acids. Also, the methylation process is also impaired. This methylation process is very important for the myelin. And vitamin B12 and folic acid is very important to provide these methyl groups to the myelin. Also, an increase in homocysteine is also important because it's related to direct damage to the myelin, and this is why you can have demyelination in a patient with vitamin B12 and vitamin B9 or folic acid. Copper deficiency is very rare. The mechanism is not clear, but you can suspect with a patient after a bariatric surgery of the patient is taking many OTC products. The patient will present with subacute combined defibrillation. You can diagnose measuring the copper levels, and here is an image. You can see the lesion in the back side of the spinal cord. The treatment is replacing the copper, and most patients will have some residual deficits after that. Vitamin E deficiency can also produce some myeloneuropathy and with other affection like retinopathy and ophthalmoplegia. Why vitamin E is important to cover the myelin in the axons of the central nervous system and peripheral nervous system is because vitamin E prevents the oxidative damage. Vitamin E catch the free radicals in the environment, and these free radicals cannot induce damage in the myelin. It's important to measure vitamin E levels, and the treatment is with 200 units per day. Another interesting case is nitrous oxide myeloneuropathy. It's very important because nitrous oxide is one of the more commonly used anesthetic agents worldwide. And also there are some increasing the use of these whitepads, these capsules full of nitrous oxide. The reason that can cause myeloneuropathy is because alter the absorption of vitamin B12. The patient will present with myelopathy, peripheral neuropathy, and some cognitive changes. The treatment is to stop the use of these nitrous NO, NO, and also vitamin B12 injections. The sensory and motor impairment persists in most of the patients. There also a patient with some cancer could develop this myeloneuropathy because these abnormal growth cells can produce new antigens, new proteins in the tumor, and these proteins are similar to the proteins in the myelin of the axons of the neurons. So the immune system attacks the tumor, but also attacks the myelin in the neurons. The most common association is anti-HU antibodies, and is present in 2% of lung cancer patients. The treatment is to reduce the inflammation and with corticosteroids. Other important pathology that could develop myeloneuropathy is Sjogren's syndrome. This is autoimmune disorder, and the myeloneuropathy is caused by many factors like demyelination, antineural antibodies, antibody-mediated autonomic dysfunction. So the cause or the physiopathology is very complex. It's important because the patient could present with these symptoms after the full spread of Sjogren's syndrome clinical. The diagnosis is with MRI, EMG, and the treatment is to control the immune response with corticosteroids, but also with immunosuppressants. HCV1 is also a common cause of myeloneuropathy, and it's called topical spastic paraparesis because it's much more common in tropical regions in the world. The patient presents with a severe progressive myelopathy with some peripheral nerves involvement. The treatment is supportive, and you can see here the lesion, and it's very aggressive form. It's a very aggressive form. And the last one, I think, HIV myeloneuropathy. HIV myeloneuropathy is also a common cause of myeloneuropathy, and the patient will present with myelopathy, with sensory neuropathy, and the treatment is with antiretroviral therapy. And the last one. Adrenomyeloneuropathy is a recessive X-linked disorder involving the ABCD1 gene. The patient presents with a slowly progressive myeloneuropathy, spastic paraparesis, and also with some erectile dysfunction, neurogenic dysfunction, and abnormal sphincter control, and can also present with polyneuropathy. You should suspect with a patient with hereditary myeloneuropathy with a family history of this disease. The diagnosis is measuring the very long chain fatty acids in plasma, and the treatment is with supportive care. Most of the patients will need to walk with assistance by the age of 50. Like you see, myeloneuropathy is a very complex and very complex disorder characterized with many symptoms and signs. It can present with a very wide range of symptoms, but it's important to recognize this disorder to prevent and minimize the disability of the patient.